Breathe in, breathe out. It's beautiful. Let's take a look at it. The respiratory cycle. We begin with inspiration. This is when the diaphragm contracts. The diaphragm is a thick sheet of smooth and skeletal muscles, so it has a involuntary and voluntary controls. That means we can hold our breath only so long, and then the involuntary component takes over. Intercostal muscles, those are the muscles between the ribs. They're going to move the rib cage up and outwards. The air pressure inside the lung is lower than atmospheric pressure, and that's the pressure outside the body. Because of this, air flows from a gradient of high outside to low inside, and flows directly into the alveoli, which are tiny sacs within the lungs. Now, in some places where there's not much oxygen, this gradient is disrupted, such as high altitudes. Oxygen and other gases are going to flow from the alveoli into the pulmonary capillaries of the lungs. You see, the lungs are surrounded by tiny capillaries and capillary beds that are going to pump CO2 out and oxygen in. Surrounding the lungs is a pleural sac, and it's composed of two thin sheets called the pleura. And there's a pleural space between these two sheets with lubricants inside. The benefit of this is, as we move around, the two sheets can slide past each other, so there's not a lot of friction. The pleura keep the lungs expanded even during expiration or exhaling. You see, our lungs are not like a party balloon that when the air is out of them, they collapse. They're always sort of in an inflated state. When the pleura are inflamed, we call that disease pleurisy. Breathing involves several variations. Let's look at tidal volume. This is the volume that we often measure when we're trying to detect acute respiratory distress and chronic illnesses, which I'll talk about. Tidal volume is simply the milliliters of air that are inspired or inhaled during a normal breath. And you can see it. It's sort of a small up and down, not a lot of milliliters in that. If you look at the inspiratory reserve, however, this is the volume that can be forcibly inhaled past tidal volume. You can see a big rise in there. So most of us have an enormous capacity for inspiratory reserve. Vital capacity, that's the maximum milliliters of air that moves out our lungs upon expiring or breathing out. Residual volume is the air that is not expired during normal breathing. Yoga experts like to say that we have this stale layer of air in our lungs that stays there unless we do prana breathing. But in reality, the air moves around in cycles. We don't have stale air in our lungs. Lung quality indicates or can indicate respiratory distress. Examples such as rhonchi, which is a snoring sound, may indicate problems such as pneumonia or sometimes obstructions in the lungs. Stridor and wheezing can indicate a narrow airway, such as in asthma. Controls over breathing involve chemoreceptors in our nervous system. They're going to detect oxygen and carbon dioxide levels in our cerebral spinal fluid that flows through the spinal cord and around the brain. There's two basic phases. The first is the stimulus phase, and that is received by the pons and medulla of the brainstem. They're going to detect low pH, which is acidic. When the blood becomes acidic, it's often due to rising carbon dioxide levels in the blood. CO2 is acidic. The next stage is called the response. Stimulus, then response. It's real typical in the nervous system. The impulse is going to travel from the brainstem, the pons and medulla, through the phonetic nerve to the diaphragm. And if you recall, the diaphragm is involved with ventilating the lungs, moving up and down. This is going to trigger rapid deep breathing, which is called hyperventilation. And through hyperventilation is one way the body can expel excess CO2. And as we expel that CO2, the blood pH tends to stabilize and become less acidic. There are some variations in breathing. One of those is nitrogen narcosis, sometimes called decompression sickness or the bends. Typically at depths over 150 feet, nitrogen gas dissolves in the tissues and flows into cells. So there's not a problem unless we rise to the surface quickly, because what happens is, as we rise to the surface, nitrogen is going to flow into the blood faster than our body can exhale it, and now we have nitrogen bubbles in the blood, and this can be dangerous. People die from it. It's very painful, and many popular diving areas have decompression tanks for this very condition. Hypoxia. Here we have a condition that's different than what I've described at the beginning. We want atmospheric pressure to be high outside and low inside the villi. In low oxygen environments, oxygen cannot follow the pathway because we have low oxygen gradients outside of the body and high in the villi. The first response to hypoxia is typically we have low levels of oxygen in the tissues, and so we're going to breathe rapidly. That's called tachypnea. And we're going to have shortness of breath, which is dyspnea. It's a frightening situation. These two gentlemen probably saved my life in the Himalayas of Nepal when I had a serious case of hypoxia. A secondary response is where we don't want to go, because we go from hypoxia to pulmonary edema, and that's when plasma from the pulmonary blood vessels, pulmonary, think lungs, fluid's going to fill the lungs, and that's going to interfere with oxygen absorption. Worse than pulmonary edema is pulmonary embolism, and that's when an embolus or a blood clot is going to break free from a vein, probably a thrombotic kind of clot, and it's going to block the pulmonary blood vessels of the lungs. This one's often fatal unless you can get help. Respiratory disorders. Tuberculosis, or TB, is a chronic bacterial infection caused by a certain group of small bacteria called mycobacteria, or mycobacterium singular. TB is spread through respiration droplets, so it's in an aerosol form when people cough. And if you have a patient that's coughing and they look old and sickly, you want to put on your BSI, you want to put on your body substance isolation, try to mask up to keep those droplets from being inhaled. Lesions or sores form in the lungs and then move to the top of the lungs, or the apical regions. So when we're listening to lung sounds, we're going to hear pneumonia down low, but we're going to hear secondary TB infections up high in the lungs. TB destroys whole patches of lung tissue, so the alveoli are gone, and then it'll flow into the lymphatic system, to the lymph vessels, and it'll spread to other regions of the body, and can become quite serious and end in death. We can detect it through chest x-rays, looking for these cavernous tuberculosis, or a sputum sample can also be done where the patient will cough up phlegm onto and then it's examined microscopically. Bronchitis, still very common, but it's cause for concern. I'll tell you why. The irritation, the ciliated epithelium that lines the bronchial walls is a very fragile tissue. Air pollutants, smoking, infections, or allergies can all contribute to bronchitis. So it's not always an infection. It's sometimes just an irritation. Excess mucus, the problem with that is it harbors bacteria. And too much bronchitis over many months, or a period of several years, starts to scar and constrict the airways. Bronchiolitis is a dangerous form of bronchitis. In this case, the bacteria start to produce enzymes that are going to dissolve the alveoli, and so they become sort of shapeless masses and replaced by inelastic fibrous tissue. And now we cannot obtain the oxygen we need. And then that may go on into cyanosis, where there's low levels of oxygen in the tissues, the patient's lips and fingernail beds may appear bluish. And there's not a lot to be done, and put them on oxygen, often for the rest of their life. So pay attention. Chronic coughing is not normal, and it's not something to just put up with. All right. COPD, chronic obstructive pulmonary disease. There are many different types. They may be caused by diseases that destroy the alveoli in the lungs. I've just talked about bronchitis, bronchiolitis, emphysema. In COPD, what happens over time is there's a tolerance to the hypoxic drive. I'm going to talk about this because the way we normally breathe is different than someone who has hypoxic drive. For example, emphysema. Normally, let's talk about normal first. The brain stimulates breathing by detecting high levels of carbon dioxide in our body fluids, mostly in the bloodstream. Okay, so think about this. Carbon dioxide is building up in your bloodstream, and that's going to stimulate breathing. In someone with hypoxic drive, the breathing is triggered by low oxygen levels in the blood. It may seem kind of superficial or unimportant, but when you administer oxygen to someone like this, all of a sudden they have high levels of oxygen in the blood, and so in some cases the patient forgets to breathe. Now, it's not quite this simple, but I want you to understand this hypoxic drive. Asthma, it's a type of COPD. It's often caused by the body's own immune system, IgE antibodies. These are proteins that are going to react with allergens. Allergens tend to be harmless substances such as pollen, smoke, or pollutants. And so this causes the release of cytokines and histamines, and they're going to flow in the bloodstream, and they're going to start constricting the bronchioles, which are branches off the bronchi. You can see in this diagram a normal bronchiole and then a asthmatic one, where the lining, the endothelium, thickens with fluid, and now our lumen is reduced. Capillaries are going to leak fluids as the mucous membranes swell, and as I mentioned, the lumen's going to close off. And this is where you have a wheezing on the exhalation. So a normal breath in, and on the exhalation, that is one of the hallmarks of asthma on the exhale. Leading cause of chronic illness in children, and it's just getting worse. Asthma does not cause a hypoxic drive, so thankfully that's one good thing about asthma. Air must be forcefully exhaled. I talked about the wheezing sound when breathing out. Influenza, we often just call it flu. Most flu viruses have a RNA that lacks effective repair mechanisms. So what this means is they can mutate like crazy. And that is why we need to get a flu shot every year, because every year there are new mutations, a nearly endless source of flu coming at us year after year. Streptococcus pneumonia is a common inhabitant of the upper respiratory tract, and it likes to become a secondary bacterial infection, such as pneumonia. After our flu is over and our system is weakened, then in steps the bacterial infection. And this is often what kills people, is the secondary infection. Feedback loop occurs, and this is because mucus in the lung becomes infected. And with that infection, the immune system is going to respond, dump more fluid in the lungs, thinking that we're going to kill the infection in the lungs, but unfortunately it just creates a better habitat. And we have this feedback loop which may end in death. In lung cancer, you have what are called SCLCs. Those are the small cell lung cancer carcinomas. These are the ones you don't want. They are very aggressive and account for many of the deaths. Adenocarcinoma, or large cell, is more common, thankfully, and a little more treatable. We use a bronchoscope to examine the bronchi to determine the extent of the cancer in the lungs. Histoplasmosis, you don't hear about this much. It's a fungus, and there are many fungal diseases out there that attack the lungs. Histo can spread from the lungs into the retina of the eye, leading to permanent vision impairment or even blindness. So this is why we worry if there's a bat loose in the house. My gosh, their urine, their feces, they may be infected with rabies, histoplasmosis. So you get out of that house, you make a phone call, and have someone in a mask and suit get that bat out of your house.